We are talking about eyelid movements, eyelid droopiness, weakness, and ptosis today. In order to talk about this topic, it's good to review the basic anatomy first. There are three major nerves innervating either the upper or the lower eyelid. The first one is cranial nerve 3 or oculomotor nerve. The second one would be the sympathetic nervous system. And the last one, the third one, is the facial nerve or cranial nerve 7. Cranial nerve 3 or the oculomotor nerve, as you notice, it's got 3 words in it. So that's one easy way to remember it for the 3 words it has. Will innervate the Levator, Palpebri, Superioris, or superior, which is a muscle that sits on the upper eyelid, and function of it is to elevate the upper eyelid. Now, notice that similar to cranial nerve 3, oculomotor nerve that has 3 words in it, the levator, palpebri, superior also has 3 words in it. So that's one way to remember this easily. The second nerve that we can talk about is the sympathetic nervous system. And the sympathetic nervous system innervates 3 muscles actually. The first one is a muscle that sits on the top. It's called the superior tarsal muscle. The second one is a muscle that sits on the lower eyelid, and it's called the inferior tarsal muscle. And it's good to know that there's a third muscle. It's a small muscle called Mueller muscle. It is an extension of the levator palpebris superior that also kind of helps the superior tarsal muscle, and therefore it kind of comes off the LPS and sits on the top of the upper eyelid. It helps with elevation of the eye, typically the first 1 or 2 millimeters of upper eyelid elevation. The third nerve to talk about, as I said, was the facial nerve or cranial nerve 7, and the cranial nerve 7 innervates the muscle that goes around the eye in a circular fashion, and that muscle would be the orbicularis oculi. Function of this muscle is, this is basically an antagonist of those other muscles. So what it does, as this nerve functions, the nerve will relay its message to the orbicularis oculi, and the eyes will close shut. So antagonist of those two, or majorly the levator palpebri superioris. Now, what type of weakness would a patient get with a lesion or dysfunction of each one of those nerves? People will present differently as a consequence of weakness of each one of those nerves. Just imagine that a person presents with weakness of this muscle, the levator palpebri superior. What's going to happen is the upper eyelid, not the lower eyelid, so that's spared, the upper eyelid will present as drooped, so it will be depressed. So that's the presentation of the cranial nerve 3 weakness. Of course, there are other findings on the neurological exam that you should look for, but that's the eyelid presentation of cranial nerve 3 weakness. The second one, the sympathetic nervous system weakness, on the other hand, that's a different presentation, and it's good to know that once this is not working, the patient will present basically with weakness of both eyelids, both the upper and the lower eyelids, as opposed to cranial nerve 3, which was only the upper eyelids. with the weakness associated with sympathetic nervous system, the upper eyelid will be drooped or droopy, and also because of the inferior tarsal muscle weakness, the lower eyelid would also be affected, and it would be a little higher than normal. At this point, it's important to talk about what's normal and what's abnormal as far as the position of the upper and the lower eyelid in relationship to the cornea and the eye. The normal position of the upper eyelid in respect to the cornea is so the upper eyelid technically should cover the limbus, and the limbus is the border zone between the sclera, or the white of the eye, and the cornea. So it's covered by the eyelid, and then it actually sits about 2 millimeters roughly on the top of the upper limit of the cornea. The lower eyelid touches the inferior limbus. A little higher or lower is supposedly fine as long as it's symmetrical, but typically should sit, kind of touch the lower border of the cornea. And again, going back to our lesion of the sympathetic nervous system, what's going to happen is the upper eyelid is lowered, the lower eyelid is higher, so the distance between the upper and the lower eyelid is diminished compared to the good eye. And you can also note that by it's covering the lower aspect of the cornea, and much more of the upper aspect of it compared to the good side. So that's the sympathetic nervous system lesion. You can also look for miosis, and if the lesion is at certain levels, patients can present with anhidrosis or inability of sweating of the ipsilateral face. And then the last nerve we can talk about is the cranial nerve 7, or the facial nerve, and that's also very important because you will see the weakness associated with that, with different lesions of the nerve, including Bell's palsy, and also you can see that type of weakness in different types of muscular dystrophy or muscular disorders. And so what's gonna be expected with this type of lesion, a cranial nerve 7 lesion or its associated muscle disorders, you would expect to see a different type of weakness. So the muscle associated with that nerve, it's the orbicularis oculi, which is a round muscle sitting around the eyes. And the function of that is to close tight or shut the eyes, the eyelids, and so therefore that's an antagonist to cranial nerve 3 for the most part, and the sympathetic innervations. And when that fails to function, people can't entirely close their eyes. So what's going to happen is, as you ask them to forcefully shut their eyes, the good side you can basically see that the eyelashes are buried on the good side, and on the affected side, the eye can't completely close. So you can see more of the eyelashes. And you can see that type of pathology again with both central causes of this type of weakness, peripheral nerve disorders, and sometimes with muscular disorders. A prototype example of the muscular disorder causing this type of weakness is a disorder called FSHD, or facial-humeral scapular dystrophy, which is a type of muscular dystrophy. It's relatively rare, but you would see cases of that if you pay attention. And what happens with that is this muscle, or the orbicularis oculi, will not entirely function, And as a result of it, for example, in FSHD, when people are sleeping at night, their eyes don't entirely close. So people see them and they notice they're sleeping with relatively open eyes. And you can also kind of notice that type of pathology in FSHD with the orbicularis ori, the muscle around the mouth. And those patients, basically when you ask them to blow a whistle, they can't do that. They can't entirely position their lips in order to make a or blow a whistle because of the orbicularis ori weakness. So going back to our topic of eyelid weakness, to wrap it up, there are 3 major nerves. Each one of them, if there is a pathology associated with them, will present with a different type of presentation, cranial nerve 3 or oculomotor nerve. The weakness is associated with upper eyelid droopiness, the sympathetic nervous system. If there's a disorder with that, patients present with both upper eyelid and lower eyelid anomaly. The upper eyelid is lower, the lower eyelid is a little higher than what it's supposed to be, and miosis. And then cranial nerve 7, there's going to be weakness of closure of the eye.